the team. That you're aware, they'll be able to, I can send this link out to the rest of the team and they can sort of listen to it. I'd like to do this in the future for all of our meetings. Just, you can put the link into the meeting minutes and then people can watch it if they feel they wish to. Anyway, so just so you know, everything that's being said is just in this recording. You might have actually got an invitation to accept so that you are aware that it is being recorded. You just say, yes, I'm aware, and off we go. So we'll get started. It is 12:04. Can everybody hear me okay? Because sometimes my mic goes in and out, so please let me know if you can't hear me okay.
Good to go.
Okay, perfect.
I can hear you.
Okay, good, excellent. So I just see Michelle is joining as well. So far, I'm just gonna do a round table because everybody knows everybody. We have Yola, Lori Harkins, Tammy, Connie, Julie, Garrett, Fran, Jenna, Emily, Kirsty, Holly, Sandy, and Michelle. If I've missed anybody, please let me know, and others may join as we.
Nancy.
Yes.
Oh, sorry. I was going to say Nancy's here too. She's just having trouble joining, but she's going to look in with me.
Oh, excellent. Okay, so you and Nancy must be working at RVH today.
That's right.
Excellent. Okay. Okay, so really, it's just going to be a COVID conversation. I'm not sure how much you guys are aware or what you pay attention in the news, or if you're listening to the news or not listening to the news. I just want to pull you guys together. So high level, as you may have heard or not, there is a new Omicron variant that is circulating around our world and is circulating here in Ontario. This variant came out just a few weeks ago out of South Africa. It has many, many mutations, 50 mutations. So it is doing, it's quite a change to how it's behaving and how it may behave. So just so that you are aware, they're watching it very closely around the world. There's a couple of things that are a little interesting with this Omicron variant, which we need to be paying attention to. It is spreading quite quickly, quite exponentially, and the province is waiting for or assuming that there's going to be exponential growth in cases in the coming days to weeks. Within the next 8 weeks, 8 to 9 weeks, they are expecting that Omicron will be the dominant strain in the province and will be probably the only strain, but it will take over for all other variants. Right now, the Delta variant of COVID has an RT value right now, meaning its reproduction and its spreadability as it infects people. Right now in North Simcoe, Muskoka, the rate is sitting at about 1.1, meaning that it's infecting a minimum of 1 people plus. For every new person that is infected, it will infect at least 1. 1 plus a hair, half of another body. So that's really a reinfectivity. It's not 0, but it's pretty low. I guess you could say it's only infecting 1 other people. Omicron is infecting, has an RT value of about 4 to 4.3. So it is infecting at least 4 people for every 1 person that it's infecting. So this reinfectivity rate is looking at about a 400% increase in cases, exponential growth over the next coming weeks. There is some data that is saying that we may be in an Omicron type of issue within early January of up to tens of thousands of new cases a day in Ontario. So we're looking at lots and lots of Omicron. It's spreading very simply as a cold-like virus. So having said that, a little bit of the silver lining within this Omicron is that people are not generally getting heavily ill. It's spreading like crazy, but people are not getting as sick and not requiring oxygen and not requiring hospitalization. And that vaccine seems to be truly, seems to be protecting us the best of our abilities. So the province, again, we sort of find ourselves, not that this is a brand new variant, but we sort of find ourselves in this, this particular 4th wave is going to be a little trickier as we navigate this new variant, and as science and our world. They're trying to understand this fully, and knowing all the nuances. The directions are changing regularly again, almost on a daily basis. We're getting new information from our health unit and from the ministry. So for example, long-term care have just been instructed that they are to limit their visitor access again. Large groups of groupings of over 1,000 people in our province. So example, if you have tickets to go to a Raptors game, for example, all of those large venues or anything that can hold over 1,000 people, they are to restrict their capacity to 50%. So all those large venues are starting to see an impact of 50% in capacity. My assumption is that over the next coming days and weeks, that those capacity limits will change again as our case counts increase. But who knows? I think that's what Ford government will really have to balance. How much people we allow them to move, comparison to shutting us up again. So it will be a bit of maneuvering for them to decide what we're going to do as individuals and how we move about our communities in restaurants and theaters and so on. However, so that is what we're sort of looking for in our coming weeks, is that this Omicron virus is going to spread quite quickly. However, hopefully people are not going to get sick. So I'm just sort of preparing you or getting your heads around what might that look like. I would say just here at Hospice, we are getting an exposure. It almost seems to be not daily, but every other, with either volunteers that have had a positive staff member or a positive family member, or they were at an event that was someone is now positive. We've experienced that within our staff as well, and we have experienced that within our residents for sure. So it's almost a daily sort of occurrence that there are these constant sort of little nips of exposure around us. So we're watching that quickly. So what does that mean for us moving forward? Well, I guess I just asking you to be patient again and flexible. There may be new directions all the time, but for now, I wanted to have a bit of a discussion, but there's going to be a few things that we're going to do as this exponential growth starts to happen. So as example, yesterday, I think we had about 1,500 cases. Today, we have 2,400 cases in the province. We will watch and see what the cases are again tomorrow. We'll really be watching the doubling time. So every time those numbers double, you can expect those numbers to double again. So if they were 1,500 yesterday, if we hit 3,000 by tomorrow, then that's a doubling time of just 2 days. So that means it might only take another 2 days for there to be 6,000. And it might only take another couple of days for there to be 12,000. Another couple of days for there to be 24,000. You can see how the trajectory goes. So we're watching it, and we will just wait and see. So for now, I would, surveillance, the voluntary surveillance, you guys can participate in that or not. That is completely up to you, but that is one thing that we can do, is go looking for it within your families, within your household. Please use those rapid tests to keep an eye on what is going on in your home. You are more than welcome to do that, just to keep a close eye. I would recommend you do this once or twice a week. It depends on your risk factors, depends on how many people are there. If you've got a family with children, you might want to do it more if they're in school, or less. Or if you've got family members that are a little more higher risk because of their practices, then you could screen yourselves as much as you wish. But at a minimum, we would like to do at least once a week if you're interested in participating. We don't want to know if you're participating. We don't want to know what the results are or how often you use them. We just want to make an assumption that you're going to do it once a week, and you can use it with your family to screen and have some reassurance within your family. So the surveillance program is out. We already have about 50 people signed up as of today. So that is awesome. So we're just actively looking for it so we can actively find it, so we can actively control it as much as possible. So that's one part. Is this?
Can I ask a question? I don't know what you're speaking of, this surveillance thing. I didn't get anything about this.
Well, it was sent out on Monday. Everybody in the hospice was sent an email with a surveillance program, a voluntary surveillance program where you can come and pick up kids.
I didn't get that, Kel. Anyway, okay. I can come and pick up kids at the hospice?
Yeah, I will. Yeah. That's,
okay.
We didn't get it either. No, I didn't get
I
it.
didn't either.
No.
Jenna, no, nobody?
No,
No.
I didn't get it.
Negative.
Okay.
Okay. Well, that's bizarre. Okay, well, all right, I'll send that out again. Okay. That's bizarre because I sent that out Monday afternoon. Okay, so surveillance data, I'll send that out to you. You guys want to, or you can sign up or not, that's up to you, but I'll send out the details of that. You just pick up your kit. She's not collecting names, she's just collecting numbers so that we can have some sort of a baseline rate as to how many individuals are participating and how many positive tests we're getting out of those tests. So there's directions in that email that if you are positive, you just let us know, and then you'd need to go and get a PCR test from public health. And then we'll go from that as to what public health instructs us to do. So anyway, so that's one, is a bit of surveillance. We're going to go looking for it and hopefully tuck it in. Number two is PPE. I think we need to sort of change gears. I think COVID is going to be with us as an endemic issue with us for quite some time. So if we start looking at this as an endemic issue that's going to be with us for a while, I sort of relate it to sort of an HIV, right? We just, we know it's there. We don't know who's infected. We don't know who's exposed. You treat all body fluids as it's contagious. I think we need to do the same mindset around this. This is a respiratory issue. We need to protect the mucous membranes of our face always, because that's the portal of entry is in through our eyes, nose, and mouth. Protect that and we should be good. So that means your hands and your face. So unfortunately, I know this is horrible, but we should go back to wearing droplet precautions all the time again, meaning you should cover up your eyes if you're going to be within 6 feet of another individual, not just clients, but 6 feet of anybody. So if you got your mask on, you should have your goggles on. You got to cover up. And hand hygiene, hand hygiene, hand hygiene. So droplet precautions are going to be implemented again for everybody. That includes admin, that includes our bell farm, that includes everybody that is around, that is exposed to other people. We should cover up the mucous membranes of our face. So that will be started as of today. The next time you work, start to have droplet contact or droplet precautions. So try to find the goggles, face protection of your choice, whatever you used before when we were wearing these, whatever is comfortable. And if there's anything out there that you guys come across or would need to keep your eyes and face comfortable, if you see a product somewhere that you like, let me know. We can try to get it in the house. Because I know, like Nancy, for example, she really liked the ones that we wear at RVH. So if you're out and about or you hear something that is more comfortable and can make your work life more comfortable, let us know and we can try to get those goggles in or face protection. So droplet precautions at a minimum and lots of hand hygiene. Please really remember to try to keep your distance. You guys do keep your distance pretty good. However, when you're sitting at the nursing station, you are a little close. So if you can, try to stay away from each other as much as you can. And please, I know you don't, but just as a reminder, I'm not sure what the night practices are. I'm confident that you guys are not eating together. I would please just reinforce to ensure that you're not at 3 a.m. having a lovely snack and a gathering at the nursing station, which I know you guys love to do. I get it. If you have, just try not to eat. Just don't eat with each other. It's just that's the risk, right? Is eating and drinking and being within 6 feet. So you want to take a break and eat together, come up to the front room. You can separate yourselves, sit at either end of the table. You have a spit guard in between you and safely have a chat and a lunch break and leave the door open. You can hear your bells and so on. So just be really careful when you're eating and drinking to ensure that we don't have any internal spread that way, because otherwise our droplet precautions should protect us. It's just that those precautions, do them well, stay to your practices, and we should be completely fine. We're watching. There is some evidence. Again, they're keeping an eye on if Omicron has some sort of, because it's so infectious, what it looks like. And if they're looking at this airborne transmissibility again. There's no directions from anywhere to say that we should increase to an N95 mask. It is still a droplet spread illness. However, there's N95 masks in the house that fit everybody. If you felt you needed to wear one, you are welcome to wear one, but we are not being instructed to wear an N95 mask as of yet. But that is one of the things they are looking at, is how airborne this is, because it's contagious. So just so that you are aware, but no directions as of yet that it is an airborne illness. We're to keep with our droplet precautions and carry on that way. But we're going to look at our occupational health and safety has had some training. We're going to do some hand hygiene auditing and some PPE auditing. So we have both of those audit tools. So just making sure people are washing their hands, because your hands touch your face, and that's how it gets into you, is by unclean hands touching your mouth, nose, and eyes. So hand hygiene, hand hygiene, hand hygiene. And of course, your PPE practices need to be immaculate and very well, and it should be good. We are going to increase some working from home in the admin office and in Bell Farm. They're going to work from home at a minimum of 1 day a week, just to decrease some bodies in the house. Right now, we are going to keep our volunteers and we're going to keep Bell Farm open for in-person client visits. So we are not closing any programs or stopping anything as of yet until further directed, if and when capacity limits come into play. So right now, we are not doing anything in regards to that, just allowing people to work maybe a day at a week at home. So the big question we need to ask you guys and have a conversation with is with visitors. So the visitor question is here again. As I said, long-term care is limiting their visitors to 2 at a time. And their directives is 2 at a time, and visitors that are fully vaccinated. In the exception of, which we have played this entire game, the whole 2 years, is with the exception of compassionate end-of-life care, which is who we are and what we do. So we are the exception to the rule. We always have been the exception to the rule. So we need to build in those exceptions into our end-of-life care. So what does that look like for visitors? We have done that. We have done this sort of dance throughout the last couple of years, down to 1 visitor, up to 2, up to 6. We've had limits of 10. We've had unlimited. There's no direction as of yet, as of today, that we should stop or eliminate any visitors. Sorry. So what does that look like for all of us? We need to talk about that. So that's one thing we need to, so sit on that for a minute, because there's also other issues we need to deal with. I want to give you an example. We are getting an admission today who has had COVID in the spring. Previously positive COVID case, symptomatic, admitted into RVH, does have a malignancy and is palliative now and is dying. They have been at home. So this is one thing we haven't been exposed to before, but this individual is going to be admitted today. They are still COVID positive, in meaning that when they swab them, they're still finding particles of the virus. However, public health, RVH, when they do the PCR test will give you X amount of, like they count them, almost the viral load. They will give you a counting number. And I'll probably not get this 100% right with the terminology, but they are counting the viral load. If you have a viral load that is less than 40, you are not considered contagious anymore. You can carry the virus, but you're not considered contagious. So this gentleman has been sent home with a clearance from the spring that he is no longer needing to isolate. His spouse does not need to take any precautions. He has no further isolation needs because he does not have a viral load that is contagious, but he may always swab positive for COVID. So, so with this notice and from RVH is managing him on droplet contact precautions as far as I understand. We're going to take our direction from them, and at a minimum, he will be on droplet contact precautions until we get told otherwise. We are going to swab him. We're expecting him to come back positive, but we are asking the lab to give us the details as to where his COVID viral load is. As long as he stays below 40, we should be good. And he has been below 40 since the spring. So each individual case we have to manage as per public health is going to allow us. So, and I think Kirsty is there. Kirsty, you could just, as a team member, and Nancy even, or people that are in acute care could help to understand this. But even after 14 days of isolation on the COVID positive unit, once they are past their infectivity rate and their isolation, even though they're actively COVID, we can decrease and stop those precautions. So, okay. So it's just, we're going to have these little nuances happening, and just know that every case or every exposure, I connect with our public health experts, and I connect with RVH, and I connect with our community support infection control team. So another example, like in room 7, right? Those nuances. She's double vaxxed. She's told she's asymptomatic. There is no quarantine level for her to do. Just as we would be if we were exposed, we're double vaxxed. There is no quarantine level for people like that. So it's only when you're symptomatic that you would need to quarantine until you get a negative swab. So we have another instance in room 4. Family have been visiting, and they have just been informed that the party or the small gathering that they were at on the weekend, somebody that's positive at that case. So I think we're going to see this daily. It's going to be a constant sort of, COVID exposures, especially if there's going to be exponential growth over the coming weeks. We have seen it already just in the last few days or the last week or so, that there's constant sort of COVID exposures. So having said that, we will watch again and listen and manage cases as appropriate, and put in guidelines. So for example, in room 4, we just heard of this. The family have not heard from public health as of yet. So we are instructing them to go and get a PCR. We will put Mr. on precautions, and we will swab him every other day until day 10. So we are just going to continue to do this. So for you guys, good PPE, your PPE and your hand hygiene is, you need to consider everybody to be contagious. And we have not had any internal spread. Our practices are tight. You do it really well. And we're going to manage each case as we go. Questions about that? And how do we want to manage visitors? Big sigh. I would suggest, if you want to, for now, we hold tight, or we reduce to have that essential visitor list back down to 6 or 10.
If we're having an essential visitor list, sorry, could we, like RVH requests that all visitors are double vaccinated? Could we not have all of our visitors be double vaccinated?
No. In all directives, this is the situation we find ourselves in. In all directives, it says that double vax for acute care, double vax for congregate care settings, double vax for long-term care, with the exception of end-of-life care. We can't. There's no directive that would support that. We can make that decision as an organization and as a team that we're not going to let anybody in the building. But I don't believe that that is what we want to do as an organization, to not allow a spouse or a child or a sibling to be at a bedside of somebody who is dying. So to just not allow people in because they're not vaccinated to have a visit with their dying loved one, I do not believe is providing good, high quality palliative care. Now there's all directives say, with the exception of end of life care. So even at RVH, they're letting people in. That is their exception. And we are making an exception. We're asking everybody to be double vaxxed, but we do have an exception that they can get swabbed and have a negative swab before they come in if they're not vaccinated.
Kelly, do you think it would be proactive if we remember, like maybe 6 months ago to a year, we kind of restricted people's path of travel throughout the house? Let's say room 7, like you said, came back positive, blah, blah, blah. We just kind of say, okay, maybe not, be in the kitchen. We can bring stuff to you. Is that something maybe we can bring to the table again?
For sure. We would do that for sure in an outbreak, but we can start to limit movement right now if you want to. Close all common rooms again, no access to the kitchen.
Well, we've
I
always
hate,
had,
I hate to do that, but just even with those specific rooms, because maybe it'll keep it more isolated. I'm just talking out loud. It is.
No, for sure.
and I just want to add to that. I think in the past, we've always had access to the room if someone was doing cares, but we've kind of opened it up a little bit more lately. So maybe just pulling back again, because what happens is that sometimes people will go into another room and then take their mask off and have a coffee. Well, I mean, we try and catch it, but I wondered too that I know we had that little contract on admission. I'm wondering if that might be a good thing to think about again for keeping masks on in the room, especially since Omicron is that much more highly contractable. Whether that would be nice to just, because even yesterday, family member came and I just happened to talk to her in the main area and she hadn't heard any of the rules as far as how things operate here. Maybe her loved one just came very quickly, but it might be something we might want to think about again, just so that families are really made aware that they need to keep those masks on as much as they can.
Mhm. So a contract for all visitors. We're going to limit movement.
I had a question about when you were talking about the levels, of the person who has already had COVID. Is that something that we're going to monitor, like on a certain amount, like certain number of times a week? The only thing I wondered about was reinfection. Like if a family member were to bring that in, we wouldn't know unless you said we can send it off to see whether that person's levels stay below 40. Is that something that we just do in the beginning, or would we do it like once a week?
No, we have a plan to do a regular swab.
Okay, oh, that makes sense.
Of course, of course. Yeah, we got to keep looking for it. We'll keep looking at it. And I just want to know if Life Labs, the differences between RVH and us is if and how and can Life Labs give us the detail that RVH can give us. That's because their normal reports they just say negative or positive. They don't give us a detailed report to say the level of infected, like they don't give us a level. So we've just got to reach out to Life Labs and see if they can give us the detail we're looking for. And if not, okay, so then what do we do? Can this guy be swabbed? Can it be tested at RVH? Can they give us the detail that we want? We just need to look into that.
And one other thought I had too was to the volunteers. If we're going to be, putting full PPE on again and whatnot to go into a room, that might affect their access to rooms again, just as we had before.
We're not doing full PPE to go in every room. We're doing droplet precautions, which just means mask and goggles. Yeah.
Okay.
Mask and goggles.
Okay. So, and then, but the room with the person with COVID positive, would that be full PPE or no?
We'll see. Yeah, we need to see. It's droplet contact. So if they're a droplet contact room, volunteers shouldn't be in there anyway.
Okay.
Right.
Okay. Yeah.
So, sorry, Kirsty, can we go back to that vaccine for all visitors?
Yeah, no, I just didn't know before when it was, I didn't know before that it was an exception for here because of the end of life thing. I just had known what I had heard from around other places. It wasn't like hey, don't let people in if they're not vaccinated. It was more of a question on so many places are locking down for only double vaxxed visitors. But I actually have a question about for this new fella who was previously positive, if we keep him on droplet contact pending his first PCR, the way that we would for anyone else, and it comes back under 40, then that would indicate that, you know, he's not transmissible. So we would take him off droplet contact at that point, right? Okay.
Yes, we're getting those instructions from RBH and Public Health. Because we have not done this before, so we want to make sure that we do it right and then it's clear. But you're right. If he's below 40, he's not considered contagious or infectious.
And we do have the documentation to say that it has resolved. And when he was sent home, they didn't feel that any kind of isolation practices were needed. We're just doing that with our due diligence when he first comes in. It's new for us, so we're sort of figuring out as we go. The interesting thing is, if he hadn't have been at RVH and had been tested, and he was tested only because he was going to long-term care. So that was sort of standard practice. So if he hadn't arrived in RVH and had that, he still would have been admitted unbeknownst to us and would have been positive, right? So at least we have the background history. He and his wife had COVID last spring.
I think it was more just the fact that I didn't want him to end up remaining on droplet contact just because he'd had a previous positive, because that almost seems discriminatory at that point.
Yeah, no, you're right, Kirsty. And I haven't talked to you guys about that sort of bits and pieces because it's been a crazy, crazy day back here. But yeah, that's part of the plan Kelly and I had discussed.
Tammy, when this gentleman was on, can you guys hear me?
Yeah, Nance.
We can hear you, Nance.
Oh, when this gentleman was on our unit, he was being sent home. He came in with 2 negative swabs and then tested positive for 4 times in a row. And then he was going home under no isolation and not being followed by public health. And he was taken off ISO prior to him going home here.
Yeah, and that's what I said, Nancy, that there was really nothing. They felt it was resolved. We're just doing our due diligence just because it's new to us. So okay. We'll start off with precautions. We'll do our swabbing and then we'll go from there. And hopefully we can get some levels from Life Labs.
That he is under the radar threshold of 40.
And he's completely asymptomatic.
So in regards to visitor numbers, do we want to make that call? Do we want to tighten that up? Do we want to make a short list of 6, 8, 10? Do we want to carry on day by day until we want to tighten up visitors, maybe early next week? Or I'm not, you guys.
I say leave it alone.
Leave it alone? Well, I'm curious for you guys to tell me, is there lots of just random visitors or people being pretty tight and being pretty good with, you know, keeping their visitation fairly tight?
I think it's family by family. I think some are very loosey-goosey and some are more like immediate family.
I was just going to say the same thing. Absolutely.
Yeah. So I think, not to be the bad guy, but I think maybe, I don't know, maybe not now, but I foresee if cases continue to climb and with the new variant, then unfortunately I would expect us to kind of tighten up with our visiting, but I don't know.
I'm finding it's not overly busy right now. There's, 1 or 2 in each room. We have 4 new admissions today. And in speaking with all of these families, there's only a couple of people coming in with these folks. So I don't expect it to be too crazy, even with it being a full house, but that's today. That's not next week.
And again, with that contract, I think it helps the nurses when, they can refer to that you signed that only 2 people are allowed at once. It's hard, and it's hard sometimes for the volunteers at the front to know how many are in, gets, especially if there's a walk, happening. So yeah, just to really make them aware when they sign that contract, what the policy is would be good. And again, with eating, not in like masks on in the rooms and not eating anywhere else.
So do we want to start there today as limit movement, start developing a contract? I can hopefully have a contract ready and people start to sign it hopefully by the weekend. I can rethink the last one and put a new date and so on, and we can go from there. We are going to randomly surveillance to visitors. So I am just going to randomly walk around and say, hey, we're doing some random tests. Would you like to participate? I'm going to see what the uptake is before we start to do mandatory test people, but I'm hoping that family members that are in the house will participate randomly. If not, we can implement screening just like we did last, I don't know what wave that was, wave 2 or 3, I think it was, I'm not sure. We were swabbing everybody. Wave 3, yeah, last week.
That's a great idea too, Kelly. That way too, you can see people scramble to put their masks on like we do. So you can call them out instead of us.
All right. Okay. All right. Any other questions, comments, concerns? So the next few weeks, I think in the next at least 4 weeks, 6 weeks, 8 weeks, it's going to be that, you know, watch for emails, watch for changing in directions. We'll tighten up where we need to. Next week, I would like to touch base with you guys. Maybe we'll call a meeting before, you know, that Christmas holiday. So maybe by Thursday for sure. But next week, we'll touch base again just to see how things are. And we'll make sure you guys are okay over the Christmas holidays. And see if we need to change anything before Christmas holidays. Okay. Question, Fran?
Oh, I was just going to say, sometimes, you know, everything is good. The house is good. The families are great. The challenge will arise on nights and weekends when there's less people in the front. And should we not have a PSW or a volunteer, then that gets really tricky to just keep on top of everyone. And that's where we've had issues in the past with just, you know, families letting people in, and just because there's not enough of us to maintain the stream. Do you know what I mean?
Mm-hmm.
Does that make sense?
Okay.
So just looking ahead, you know, just kind of keeping our eye on that maybe, you know, if there's only a limited amount of people in the house, maybe that's where restrictions could be applied, like not so much applied, but maybe people encouraged to plan their visits when there's more people around to help screen and stuff like that. Does that make sense?
Yeah, like an encouraged visiting hour, you know, try to visit between 9 a.m. and whatever time. Is that what you mean, Fran? Yeah. Okay.
Yeah, that's what I was thinking.
Mm-hmm, mm-hmm.
Just an option.
Yep, yep. So would you say like increased support after hours? Is that what you're sort of?
Well, that has certainly been helpful in the past when we wanted to be diligent with surveillance and screening and stuff like that. That's been very helpful in the past.
It does seem to be whenever issues arise surrounding that, it is an after hours thing.
All right. So what would those hours look like? Like if there was extra support, what would that look like? Like until 10 at night, until 11?
Even till 10 was nice when we had that. And then if it was a quiet night, the volunteers used to say, oh, it's quiet. Is it okay if I leave early? And we would just kind of play it by ear.
So just to let you know, over the Christmas holidays, from the 24th to when we opened the office back on January 3rd, the reception desk is fully booked for volunteers for all shifts. We've been very lucky. I'll be honest, I don't know if we're going to get very much uptake to stay till 10. The other thing that we're going to be doing is, because the offices are closed during Christmas and New Year's, we're going to keep the front door locked 24/7. So that just because there isn't as many people in the office, so we are going to keep the front doors locked to help control people coming in and out. But I don't know, we can ask to see, Kelly, if people will stay till 10. I'm not sure we're going to get that uptake. It's taken us a long time to just even to get the 5 to 9 shifts covered.
Yeah, Connie, you and I can talk about that as to
Yeah.
to increase that. Yeah. Okay. Okay. All right, any other questions or comments, concerns? All right.
We just had something else come up here. So if we have a patient that has had that secondary exposure from a family member who's had exposure, but now there's visitors in their room who are not wearing their PPE, are they considered like a tertiary exposure?
No,
What is going on?
we have no positive cases in the house or any symptomatic. I know it goes on and on and on, but
We're just looking at the walk-in and we're like, uh-oh. Yeah, now what?
no, you're only really truly high risk exposure, considered a high risk if you have been 15 minutes within that 6 feet of that individual for prolonged visit of more than 15 minutes. In the space of a positive person for 15 minutes with no PPE is considered a high risk exposure. So none of us would be ever considered a high risk exposure because we just don't do that. We're never 15 minutes without PPE within 6 feet of somebody. Unless, like I said, you guys on nights might want to share a pizza or something, you might sit there for 15 minutes at that nursing station with your mask off. And so that kind of thing just can't happen. So if that is happening, I'm encouraging you to not allow that to happen and ensure if you're going to eat together to make sure you're 6 feet apart. And we're never within 6 feet for 15 minutes with our clients, with our family members. So we don't expose ourselves to high risk environments or high risk issues because we are not.
Just curious. I swear I'm not being difficult. I just have a question.
No, I know it's fine. No, it's good. Be difficult, Kirsty. It's okay.
So for the Omicron, since it is like it's got such a higher virility there, is that still the 15-minute rule, do you think?
Oh, as of right now, I know that might change to be less than a minute of considered a high risk exposure right now. So when they have large outbreaks of Delta in large organizations, the high risk exposure was down to a minute without PPE. In outbreak situations. Right now, that's not outbreak situation. And right now, that's all the guidelines that I'm aware of is a 15-minute is considered an exposure. Again, that'll change, but even still, we should never be a 1 minute without our PPE. We should never, ever be a high risk exposure period because we have our PPE, we're covered up. We're covered up our eyes, we're covered up our face, we wash our hands, we keep our distance as much as we can. And we're all double vaxxed to triple vaxxed. So I can't imagine we would ever be considered a high risk exposure unless we do that purposely or accidentally. I'm not sure how that would happen, but we just need to be really, really diligent.
Kelly,
Yes.
I haven't been there like since the whole incident happened last week, but our lady that was a high risk, what was the outcomings of that? Like, she continued to visit, she didn't have to isolate, but she was high risk. What was the
But
whole?
she wasn't
thought?
determined to be a high risk. That was the thing. She wasn't
she-
determined to be a high risk.
Dinner with a positive person isn't high risk?
She was double vaxxed and she didn't spend 15 minutes within 6 feet of a positive individual. So there was a lot of nuances in that.
Right.
The person was not considered positive because it was a rapid test, so not a PCR confirmed case for one.
Mhm.
Even if it was first case, the individual, we can only take her at her face value, said that
Right.
she did not meet that criteria. She was not within 6 feet for prolonged of 15 minutes with that individual. So I don't know. That is what I'm understanding. That is what had been told to us. Even when I told public health that even if she was considered a high risk contact, would her behavior be any different? And should we treat her any different? And they said no. Swab her day 1, swab her day 5, should be fine. She is asymptomatic, double vaccinated. So was the entire household, double vaccinated. They did not feel that her exposure risk was considered high risk.
Okay.
And I guess that's what, I guess it doesn't, not that it doesn't matter, it matters, it absolutely matters. There's going to be people walking in our building all the time that don't even know they've had a high risk exposure. Like they just won't know, or they don't know until 5 days after the fact, like exactly what we're seeing right now in room 4.
Mhm.
We don't know. So we just need to be diligent with everybody and cover up, and we will follow up as much as we can to ensure, but there's going to be cases that we just don't know. We don't know. So we just need to be tight with everything, because there's going to be, it's going to walk in here and we won't know.
Okay.
We won't know until it's out of the gate. So, and I can say that might happen tomorrow. It might not happen until 3 weeks from now. But if we're going to see an exponential growth of tens of thousands of cases by mid-January a day, we will get, someone will be positive within our group. I can say that's fairly, it's not an if that's going to happen, it will be a when. And so how long can we hold it down and keep everybody as safe and healthy as possible? So that's what we're sort of preparing for, is that it's not an if, it'll be a when. And for your families as well, for you guys to have that when, like if there's going to be, as they say that may be, I don't want this to be a scare tactic or that's not what this is. This is just from what I understand from reading. I don't know if it's going to happen. We might not ever have 10,000 cases in January. I don't know. But the government will have to decide what we're going to do and how we're going to manage that. And right now it's just day by day. So again, watch those. If you want them, I can send them to you. We get a daily update as to new cases a day. I can send that along if you want to see it. If you don't, you can just ignore them. And we'll just watch daily case counts.
Another question, we all gave proof of vaccines, double vaccines. Do you want the boosters? Nope, okay.
Well, we will if right now being fully immune, the definition means 14 days after 2 vaccines. Okay. If they tell us that fully immune means 14 days after a booster, then we will ask for the booster. Right now, mandated vaccine means 14 days post two shots. So no, we won't ask for that until the definition changes. Okay. Then we will need to ask for that, if that makes sense.
Good, yep.
Okay.
I was just going to say again, what, from what little I understand from about Omicron too, is that again, PPE is so essential because that's our really first defense, because it is more vaccine resistant from what they see. And so that's so important for us to encourage for ourselves and families to keep that up, I think, more than anything.
I don't know if it's been determined that it's vaccine resistant. I know that there is some changes to the spike protein that our vaccine has been made to work with. So there are some changes within that spike protein that they're really looking at to see how effective or how vaccine shifting it is. So again, everything just says that we just don't know enough about it. It's just come so quickly, and science is trying to catch up. So I think we're just all sort of just waiting to hear what happens and watch and see. I'll be very interested to watch that doubling time. Let's really watch doubling time, and then we'll know what we're looking at. Anyway, the next days to weeks will be interesting, at the least, to say the very least, will be interesting. I know there's been conversations already, major hospitals, and I don't know if RVH has as of yet, but stopping closing down the ORs again to prepare for an influx of people. So we'll wait and see. So look after yourself. Try to stay emotionally stable. This is not going to be an easy winter, I can imagine. It's going to have some challenges. We're going to have some challenges as we have over the last couple of years. So just try to stay positive, stay informed. I would like you to encourage you to chunk it down. It gets big, it gets overwhelming. If you look at numbers, you look at what's going on in the province, you look what's going on in the world, it gets a little daunting and a lot to take in. So chunk it down, take it day by day, shift by shift, deal with what you need to on that shift, wear your PPE, wash your hands, keep your syndromic surveillance. Please don't come in if you're ill. If you do have cough and cold symptoms, please go and get do through a PCR. You should not be coming here if you're symptomatic in any way, shape, or form until you have a negative test. Once you have a negative test, you're welcome to come back here as long as your symptoms are improving. So get a PCR test, and then you're welcome to come back to work. But really watch yourself for symptoms. Do the voluntary surveillance rapid tests if you wish to participate in that. And I guess just, try to just keep it shift by shift and try not to take on too much of it. And we'll deal decision by decision, crisis by crisis, case by case, and make it the best and just chunk it down by the days instead of chunking it down by what the next few weeks and what the next coming months are going to look like. Try to keep it to your shifts, and when you're off, make sure you're filling your cup the best you can and doing things that are going to keep you mentally, spiritually, physically healthy. And we'll do our best to get everybody through this healthy and hopefully outbreak free. Dan, can't hear you, Dan.
Can you hear me?
Yep.
Okay. So I know in the beginning, if we had people traveling from outside of Ontario, that they would have to gown up and full PPE if they're coming in to visit. Are we going to go back to that now with the Omni being so?
We're going to follow what the government puts in for travel. Right now, there is no travel restrictions. There's no travel coming from South Africa, and that is it. There's a list of countries that you're not supposed to travel to. However, just the other day, it does say that all unnecessary non-essential travel, Canada is saying, please do not travel if you don't have to, but they have not put travel restrictions. So we will put travel restrictions and limit our visiting based on those travel restrictions. So until then, we won't.
Okay.
Until we get told otherwise. Yeah.
Okay. So the question about the 14 days, it doesn't really skew whether they can come in or not? Like on our questionnaire, it says if you travel in the last 14 days, it doesn't really affect whether or not
outside of Canada. Yeah.
Okay.
Yeah.
Okay.
Okay. So far, unless you've been to Zimbabwe and South Africa, but
hey now,
that, no.
easy.
No, I'm just saying, just don't go to Zimbabwe right now. It wouldn't be a good
You just choose my country out of all countries.
I know. Well, and unfortunately, Michelle, this is where Omicron has come from, is right from South Africa. Epicenter of this.
Dr. Shears is in South Africa right now.
Oh, is he? So, so I've taken an hour of your time. Thank you so much. So I'll send out these minutes of what we've discussed today. I do want to just add one more thing. This is not COVID related at all, but there's going to be, so let's back her up. HR stuff for all of you involved. The full-time RPN posting was up and is now down. We do have a successful candidate. We do not have any offer letters or anything signed as of yet, but hang tight. We're hoping to make that announcement any day now. And the manager's position is the same. We are going to be making an announcement, hopefully any day. There is going to be a posting that is going to be coming out. Again, I hope to get it out of here by Friday at a minimum, but we are going to be hiring a full-time RPN or RN, whomever. We're going to have a full-time internal posting to have a ditto to Michelle. So this will be a palliative care nurse navigator role in the community. Michelle is seeing, so the growth over in that clinic is exponential and is crazy with 2630 visit referrals in a week. It has been awesome. It's a great problem to have. And thank you to Michelle. And Tammy have carried that load. So Tammy is helping Michelle to get through those referrals. She's taking sort of the overflow. So Michelle is seeing everybody that is currently getting chemotherapy, radiation, still coming into the cancer center. So that position, she is seeing people that need to be seen in person or that are going to be seen in person. Tammy has been following up. So this role will be sort of a hybrid, but it will be a remote type of job. You will not necessarily be seeing people in person. This will be a phone / Zoom / Tammy, I think, has been doing most of it by phone call. This will be phone call follow-ups to do some symptom assessment and navigation to ensure that they have primary care connected to them and to ensure that they have home care supports and such. But there would be an orientation process. But we want to get an internal position posted, and this will be a full-time position. Right now, there might not be full-time hours. We're waiting, but I know within a couple of weeks it will be full-time hours, and we could certainly put a full-time hours around that. So that posting is going to go out, and we would like somebody to fill that ASAP. So watch for that. But this might be a remote that you might work at home. We might be able to find you an office station at Bell Farm. We may be able to put you in an office here, even though but we're pretty strapped. We're pretty limited for space. So it might be a bit of an at-home position with a laptop and a phone and so on. Anyways, very exciting, but growth is happening, and there's going to be a full-time position for a palliative care nurse navigator. A palliative care nurse navigator with the oncology symptom management clinic. And we feel that a team is a good team. We have excellent RPNs within our mix, and we have excellent RNs within our mix. So we're going to put it out for nursing in general, and we will see who is interested. And as long as you have the skill set of good palliative care, then we could move you forward with an interview. Anyways, hang tight. That's coming soon. Hopefully in a day or two, by Friday. Hopefully that posting is out. Okay. So you'll be working with Michelle. Michelle is full-time, and they have right now a 0.5 admin assistant and a whole team of palliative care docs. Right? Is there anything, Michelle and or Tammy, that I should add to that to get people enticed and interested?
It's been incredible watching this clinic grow in the last year, and I've been working closely with Michelle. I wish I could give Michelle my full-time hours, but it's amazing and so rewarding to see people linked, and even just having them talk with you, sort through their pain medication, link them with the doc. Yesterday we had a situation where somebody was really falling through the cracks, and I think Michelle ended up talking, I ended up talking to them. But it's so rewarding to see people connected and having good journeys. I know it's super busy, but I think with somebody dedicated completely to that role with Michelle, it would really make it seamless. So Michelle, more your baby.
I mean, enticing wise, it's all doctors that you guys all work with all day, every day. So you know the doctors already. For the most part, I think the kind of game plan we came up with is that I will be dealing mostly with our doctors in clinic, but doesn't mean that you guys won't. It's a lot of networking between family doctors, and Tammy, my clerk, and I have kind of come up with a spreadsheet as to who does and who doesn't. Again, a lot of the family doctors here in Barrie are doctors that you guys see come into hospice, and provide care that way. So you quite often know those doctors and their capacity already. I mean, to echo Tammy's, it's very rewarding. There are days I go home pulling my hair out because I'm a little overwhelmed, and there are other days I go home just feeling like I made a difference. For the first time today, Kelly, I actually spoke with a patient who they have had a family member through our clinic, and they had nothing but amazing things to say about our clinic. So that's the first time I've had some feedback that way. The patient's son-in-law came through our clinic. So yeah, it's very rewarding, and it opens your eyes to how big things really get, because this is a regional cancer center. I see patients from all over. And I will admit, not all of the patients that are being seen by family doctors have gone to Tammy. I still am working on a pile in the corner, and kind of networking that way. So I do think it can definitely build another full-time role. And yeah, I'm just eager and happy to have somebody help, because as it is, I'm working way over hours, and I need help. So yes, apply, come play with me.
Yes, and I think the vision is in time. I think just because of COVID has thrown us a little bit sideways, but the goal was within 12 to 18 months of starting the clinic, which was last September. So we've got our 12 months in, we're working on our 18 months, that it would expand to disease agnostic. So this will not just be a cancer related program. Right now, we need 2 FTEs to deal with just cancer. So I can see this clinic or this role expanding to another nurse to do respiratory, cardiac, and renal. So the team, I believe, will continue to grow. I would assume that we're probably going to post again in the summertime for an expansion of this role to disease agnostic, so our chronic disease management. But anyways, just so that you are aware, there is that posting. So we're going to post it internally. We're going to cast our net, because I truly believe we need to grow within if we have the skill set there. I would like to grow within and have somebody join Michelle. If we don't get any candidates, then of course we'll cast the net externally. But anyways, there'll be some movement. Anyways, that's about all, to end on a more positive note instead of a COVID note. All right. Everybody all right?
Kelly?
Yes, dear.
Could I talk to you privately after this is done?
Certainly.
Okay.
Okay, I will stop the recording whenever everybody leaves, and then you and I can have a chat. Absolutely.
Okay.
Perfect. Okay, guys. Well, thanks then. So we'll I'll send out that voluntary surveillance. I'm just writing my notes. Voluntary surveillance invite. I'll make sure that you guys all get that. You're welcome. And everybody's going to start droplet precautions all the time, mask and goggles whenever you're just your whole shift. And we'll follow regular precautions as we have with all clients. Like, that's not changing, but droplet precautions always. And visitors will look at starting that contract. We're going to limit movement within the house, and we'll look at some increased supports after hours. And we'll meet probably in a week if there's significant changes. If there's no significant changes and we're status quo and the case counts remain at 1,000 or 2, and we're just sort of coasting, I won't call you together. If case counts are 6,000 next week, we'll call you together and we'll take a look and see if we need to re-strategize. Does that sound like a fair enough game plan? Everybody feel safe with that?
That sounds good to me.
Sounds good so far? Sandy's nodding. Yeah, Fran's okay? Okay.
Sounds good.
Yeah, Tam? All
Yeah.
right.
Yeah. Stay
Okay.
safe, everyone.
All right, then. We're able to sign off. All right, guys. Then
Okay,
take
goodbye.
care. Okay, we'll see you later.
Thank you.
Okay, thanks, guys. Okay, bye. I'm going to stop this recording here, Lori, now.
Okay.
If I can. Just 1 minute recording.